So good evening all. So I'll just directly go to a case. So whenever a patient comes with vertigo, dizziness or imbalance, we are remembered. They are referred to the ENTs or the neurologists as the most common cause of vertigo is peripheral vertigo, that too BPPV. So here I'll be sharing with you two cases which I encountered in my practice and I felt it is very much worth sharing. So coming to the first case, this 44-year-old female ended up in our emergency department with complaints of severe vertigo. So her neurology evaluation was already completed from emergency. Her MRI brain and angiogram was normal. So she was referred to me. ENT consultation was made to rule out a peripheral cause. So I'll just elaborate her history. She had new onset recurrent external vertigo of 1 month duration. It was spontaneous and sometimes triggered by visual stimuli. It was lasting around 1 hour. It was associated with vomiting. And now for the last 15 days, she was having unsteadiness, phonophobia, and photophobia. And for the last 15 days, her vertigo was almost continuous. And now she cannot move her head from side to side as the head movements triggered her vertigo. She had already taken treatment from multiple centers and she had no improvement, and some of them had even labeled her as functional. So I did my job. So I did a position test with Frenzel to rule out the most common cause. It was negative for BPPV. So a complete vertigo evaluation was done with video nystagmography. So these were the findings. In horizontal saccade, she was having right beating nystagmus in right gaze and left beating nystagmus in left gaze. So in vertical saccade, she was having upbeating nystagmus in up gaze and downbeating nystagmus in down gaze. So her horizontal smooth pursuit was completely saccadic. Her vertical smooth pursuit was also saccadic. She had gaze evoked nystagmus both with and without fixation. So we know it is not functional. She has so much of cerebellar findings in VNG. So when there are cerebellar findings in VNG with normal imaging, what should we do? Where to look further? So here comes the question, can it be a paraneoplastic syndrome? So we evaluated her. Her chest X-ray was normal. Her USG abdomen was showing peri-immature teratoma in the right adnexa. Her CT abdomen was showing heterogeneous lesion in right adnexa. Her CT abdomen also showed enlarged retroperitoneal, peritoneal, and inguinal nodes. Since we had the nodes, we did a biopsy from the left inguinal node with the help of our interventional radiologist, and the report came as metastatic adenocarcinoma. This is a histopathology report. So we came to a conclusion. It's a case of ovarian malignancy with lymph node metastasis with paraneoplastic cerebellar degeneration. So the journey started with complaints of vertigo. The patient came in the emergency department, evaluated by the neurology team, ended up in ENT, and now in the loop, we included the gynecologist and the oncologist. So there was a multidisciplinary team approach with the gynecologist, oncosurgeon, medical oncologist, and the pathologist in the loop. So a treatment plan was devised for her. Neoadjuvant chemotherapy, that's paclitaxel and carboplatin-based chemotherapy was given three weekly. And the plan was to complete 3 cycles of chemo and reassess with CT and then plan interval debulking surgery, or complete 6 cycles and then plan surgery. So I will tell you what happened to the patient at the end. Before that, a few words about the paraneoplastic syndromes. Paraneoplastic syndromes are uncommon manifestations seen in different malignancies. It is not the direct consequence of invasion. It is not the consequence of metastasis. It is not the consequence of cancer treatment. And paraneoplastic cerebellar degeneration or ataxia as a paraneoplastic syndrome as such is very rare, less than 1%. And the most common neurological paraneoplastic syndrome is cerebellar ataxia. It is seen in breast and pelvic malignancies, especially Hodgkin's lymphoma, gastric cancer, prostate cancer, small cell lung cancer. So whenever we are suspecting a paraneoplastic syndrome, the aim of the treatment is to identify the primary site at the earliest and treat the primary so that paraneoplastic autoantibodies are not produced and target the autoantibodies. So who are these autoantibodies and who is damaging the cerebellum? So autoantibody is a culprit. So paraneoplastic cerebellar degeneration as such is an inflammatory autoimmune process where there is destruction of cerebellar Purkinje cells. Anti-O is the most common antineuronal antibody. It is commonly seen in breast and gynecological malignancy. It starts as localized disease and then gradually spread. So in these cases, early intervention is very, very important. Now coming to management. So whenever we suspect the paraneoplastic syndrome, the first objective is to identify the underlying malignancy at the earliest and treat the underlying malignancy at the earliest. So since we have the autoantibodies which destroy our cerebellum, we need immunomodulation. These autoantibodies have to be removed. So immunotherapy is recommended. Systemic corticosteroids, intravenous immunoglobulins, plasma exchange, cyclophosphamide, tacrolimus, and rituximab is recommended. And as far as possible, surgical management of the primary site, if it is feasible. So coming to onconeural antibodies or paraneoplastic antibodies. Anti-O is the most common onconeural antibody. It is seen in paraneoplastic cerebellar degeneration, especially breast cancer and ovarian cancer. Anti-HU is seen in small cell lung cancer, prostate cancer, seminoma testis. Anti-RI in breast, ovarian, and small cell lung cancers. Anti-TR, VGCC, MAR2, CRMP5, GLUR1 are other autoantibodies. Anti-VGCC is an autoantibody which can be seen in non-malignant conditions also. So when can we say that a patient is having definitive paraneoplastic cerebellar degeneration? If there are cerebellar symptoms for less than 12 weeks with normal brain imaging, moderate disability score in modified Rankin scale, if there is clinical evidence of ataxia with established cancer diagnosis within 5 years of symptom onset. That means if we are suspecting, we have to keep the patient under surveillance till we find the malignant site. Or if there is cerebellar symptom and if we can prove an onconeural antibody, if we can pick up an onconeural antibody, we can consider it as a definitive paraneoplastic cerebellar degeneration. So probable paraneoplastic cerebellar degeneration if there are classic symptoms without onconeural antibodies. In such case, don't just leave the patient telling test functional. Please evaluate the patient. Continue evaluating the patient with imaging including PET. Repeat the paraneoplastic antibody as at serial intervals, and the patient should be kept on regular surveillance. So this is our patient. So when she came to me, initially this was her gait. It was actually an ataxic gait. And these were her eye findings, her right beating nystagmus in right gaze and left beating nystagmus in left gaze. So finally, this patient has completed her chemo and now she's doing well. She has no complaints of vertigo, but she is able to walk only with support. Previously, she was not even able to stand without support. And she has not completed her surgery yet. And within 1 month, like I evaluated this patient, and after 1 month, another patient came to me. This was a 36-year-old female. Her complaint was she has vertigo on looking up and looking down. So I will elaborate her history. She was in USA. She was in an administrative post in USA. She was having high stress at workplace. She was doing very well in her job. And 4 months back, she suddenly noticed unsteadiness. It was following fever. The unsteadiness was insidious, but it was gradually progressing. And recently, 2-3 days before, she had noticed a change in speech. The whole workup was done from USA. Her MRI brain with contrast report was there, it was normal. Serum B1 and B6 was normal. They had done an LP study, which was normal. The heavy metal panel was also normal. So since everything was normal, she was labeled functional. But taking history, seeing her profile, knowing her, I felt it is never functional. There should be something. So I did my job. I did a position test with Frenzel. I could tell them that it is not BPPV. So these are her findings in BNG. She had saccadic hypermetria in horizontal saccade. And there was saccadic hypometria in vertical saccade. And there was some broken smooth pursuit in downward gaze. And head shake, minimal downbeats were seen. So this was her gait. And here also, cerebellar findings with normal imaging. So where to look further? This patient came to me 1 month after the first patient. So I was definitely thinking about paraneoplastic syndrome. The whole paraneoplastic workup was done. Her chest X-ray was normal. Her USG abdomen was normal. Her mammogram was normal. Her MRI brain was reported normal. So now what to do? We have a very good neurology team who form a very good team for me to work with. So I associated with the neurologist. So PET CT was done. There was diffuse hypometabolism involved in bilateral cerebellar hemisphere. There was no FDG focus suggesting primary malignancy. The features were revealing mild cerebellar atrophy. So it is not functional. So we labeled it as it is a case of severe cerebellar signs present, but primary malignancy not detected. So the following investigations were done. Paraneoplastic antibody panel. It was positive for VGCC. VGCC is an autoantibody seen in malignancy. It can be seen in autoimmune conditions also. So autoimmune panel was done. It was strongly positive for RO52. She was showing hypocomplementemia also. The DNA profile was done. DS double standard DNA was negative. So we came to a conclusion. It is not functional. So currently it cannot be termed paraneoplastic. So it is autoimmune definitely. So possibility of connective tissue disorders, Sjogren's. We had seen some papers where they tell Sjogren's can cause progressive cerebral ataxia. So we took a biopsy from the sublingual gland. There was occasional duct with mild periductal lymphocytic infiltrate. The Schirmer test was positive. So we came to a conclusion. It's a case of rapidly progressive cerebral ataxia. It is VGCC positive, undifferentiated connective tissue disorder, RO52 strongly positive. So we started treating the patient. She was given, they were really affording. So we could give her IV immunoglobulin, injection rituximab. Extensive neurorehabilitation was done. So our plan was to continuously search for malignancy and she was kept under regular surveillance. We plan to repeat the PET after 3 months. So coming to autoantibodies in cerebellar degeneration. The autoantibodies which cause cerebellar degeneration can be either paraneoplastic or it can be non-neoplastic. If it is paraneoplastic, we have to treat the malignancy and deal with the autoantibodies, that is immunotherapy. If it is non-neoplastic, we can go for immunotherapy. So this slide I got from a neurology colleague. So he just shared me this one. If there is a suspected paraneoplastic syndrome and if it's classical, we have to do tumor screening first. And if the tumor is present and the antibody is present, we have to treat the tumor and do targeted therapy. Here we were using rituximab. If the tumor is present and the antibody is absent, tumor treatment and immunotherapy. If tumor is absent and then antibody is present, we have to continuously screen the patient. Tumor surveillance should be going on and targeted therapy. If both are absent, you have to think about alternate diagnosis also. So most common autoimmune antibodies in cerebellar degeneration are peroxidase and thyroglobulin. It can be seen in thyroid and autoimmune disease. Anti-SSA, SSB seen in Sjogren's syndrome. So coming to our patient, the second patient, after 6 months, she left us after this treatment and they were already in US. And these details I got from our neurologist. So from there, they did a autoantibody titer. It was some newer technique which was not followed in India. He told me it is not FDA approved. So Purkinje cell cytoplasmic antibody type 1 is positive. it corresponds to anti-O. So when the autoantibody was positive, when the paraneoplastic autoantibody was positive, her MRI pelvis was done. So there was some mixed cystic solid lesion in the left ovary. They did a surgery and it turned out to be ovarian malignancy. So finally, this one also turned out to be paraneoplastic. So the importance is we should keep the patient under constant surveillance. So second patient is a case of cerebellar degeneration, which is secondary to neoplastic autoantibodies. So coming to the take-home message, if there are cerebellar findings, even if the imaging is normal, we have to evaluate the patient completely and never label a patient functional unless we have evaluated her completely. And autoimmune cerebellar degeneration can be paraneoplastic or neoplastic. If the basic paraneoplastic workup is normal, we can go for paraneoplastic antibodies and autoimmune antibodies. So early diagnosis and treatment with immunoglobulins is needed to prevent further progression of the autoimmune damage of the cerebellum and brain damage. So in any case of vertigo, never restrict the case to an ENT because in many cases, the vertigo may be pointing to some other major disease. So a multidisciplinary team approach and open mind is always crucial in vertigo management. Thank you so much.
Oh, so that was brilliant. I think I should give you an applause. I have never sat through a presentation like this silently. I've been amazed. I think this is fantastic, and I would love to open this to discussion with Dr. Rajiv. So, first and foremost, Dr. Rajiv, I would like you to comment. How many patients do you diagnose as functional, and how many would you chase like she has done?
First of all, let me congratulate Dr. Danya. It is a Herculean task, not as simple as she presented. She presented it very easy for us to understand. But to getting the confidence of the patient, maintaining that confidence, and building the team who will investigate despite getting multiple negative reports is a really difficult task. So she has done a very huge job. Congratulations, ma'am. I have seen quite a few patients having this sort of clinical picture, but most of the time, the patient is not diagnosed in the first few sittings. And it is very important to get a neurologist who will support you and investigate the patient further. And that is where we lose most of the patients. I'd like to share an article, if it's all right, on the chat.
Sure, please.
Which I recently went through. So it gives us a better picture about this condition which Dr. Danya has presented. So what to do in case there is a patient with a normal neuroimaging and cerebellar features? What are the differential diagnoses? So as she mentioned, it could be paraneoplastic, which is a huge part of the disease burden. And non-neoplastic can include toxicities and other autoimmune conditions. And it can also be some genetic conditions which are not very common or not, medical professionals are not very well aware of these conditions. When I look back at my practice, I know that I have had patients without a diagnosis with mild cerebellar features and mild Parkinson's features who probably had this as a paraneoplastic syndrome or other autoimmune condition, but unfortunately could not be diagnosed because nobody is willing to accept cerebellar diagnosis when the imaging is normal. So that was the challenge in most of the cases which I faced. Hardly, I think, autoimmune diagnosis with a proper, positive report, I can probably think of only one or two. And one more publication which I went through, I'd like to share with you all. So autoimmune conditions do affect cerebellum, of course, but they also affect the inner ear as well. And it is more unusual or less acceptable to give this diagnosis compared to a cerebellar dysfunction because the autoimmune inner ear disease affecting only the vestibule is still not a well accepted condition. And studies are very difficult because, as you know, we can't take a biopsy of the vestibule or the cochlea. We do come across a large number of patients with other autoimmune inflammatory conditions like ulcerative colitis who have vestibular pathology. and it becomes difficult without the supporting literature to convince the other professionals that this is the cause. But we should, as you all know, vestibular medicine or neurootology is a very evolving science. So we should keep our eyes and ears open and our minds free to come up with appropriate diagnosis. And I think with the help of others with these sort of meetings, we would become aware of these conditions, and it's better for us in our practice.
So that is brilliant. So here's the questions which come to my mind, and I'd be happy if Dr. Danya and then Dr. Rajiv were to attempt to answer it. Is it that in paraneoplastic syndromes the lesions are limited to cerebellar manifestations, or do you have other neurological manifestations? Dr. Danya?
So in cerebellum, sir, they say ataxia is a common manifestation.
Right.
So vertigo as such, I could not pick up any work. But vertigo is one of the symptoms which I came across.
Yeah.
But the antibodies which cause the cerebellar degeneration is the present with the
No,
ataxia.
no, my question, it's a tough question because I don't claim to have vast experience. So I'm not asking this to question you, but more to ask whether anybody actually has information in this regard. That if you have a paraneoplastic condition, which is presenting with CNS manifestations, is it invariably cerebellar, or can you have other neurological manifestations?
No, sir. I think if you go to the article which I shared the link,
Yeah.
and also in my experience, there are other neurological features which don't
Right.
meet classical neurological diagnosis. So you will find that, I mean, at least I found in many of the patients whom I have seen that they have features of Parkinsonism, relatively expressionless face and a shuffling gait, in addition to the mild cerebellar features. So even in the article, they have mentioned that there can be the Parkinsonism also, and other neurological features such as generalized atrophy and other features can be there in autoimmune conditions.
Okay, so then, so
yes.
I go back to Dr. Danya. What did your neurologist say? Is it localized to the cerebellum, or could it be elsewhere? What did he say?
So actually the autoantibodies can damage the whole of the brain. It's not like
Correct.
it will not be always localized to cerebellum.
Correct.
But I think the cerebellar Purkinje cells are the most common target.
Okay.
So, yeah. So that may be the reason why the balance is affected first.
Okay. So I think, this is, of course, trying to appear smart when one is not, but I think the weight of discussion would suggest that you should look for the entire CNS to be examined very meticulously, like your classical undergraduate CNS examination. So that is, one should not take a message that it is cerebellum which manifests as this thing. It is neurological in general, cerebellum in particular, because it shows up as vertigo and therefore relevant to us. But here's a follow-up question, also induced question in my mind, induced by your talk. We tend to, if we suspect intracranial pathology, we tend to ask for an MRI. If it is normal, we tend to repeat the MRI. How many of us do PET scans? I was intrigued by the fact that you did a PET scan. Why did you do a PET scan? Did you do a PET scan after an MRI, or you did it primarily?
No, sir. The MRI was initially normal. So when we
Okay.
evaluated, definitely everything is turning out to be normal. But since the VNG is showing the abnormality, since the picture is pointing towards paraneoplastic, whenever we are suspecting paraneoplastic, we are expected to extend our evaluation, including the PET. The whole body PET should be done, but we did a PET scan of the brain. Actually, in the doing a PET, it's the neurologist who ordered for the PET, not myself.
No, so I think that's very interesting that if you suspect a paraneoplastic, I would agree, as you said, that a PET would help you, especially find out, FTG avid lesions, which are very small elsewhere in the body also. It's very much like an occult primary being picked up. So I'm just, intrigued by the fact that PET of the brain was chosen. And I thought that maybe needs to be gone into a little in detail. So I was wondering whether your neurologist could enlighten us. Maybe you could do it afterwards as to why he localized it to the brain.
No, sir. Actually, this patient actually came 1 month after the first one. So I was telling the neurologist that this is of the same picture. So the MRI may not be normal. So since we could not find anything, nothing paraneoplasty we could find in our first search. The first case was easier. So in the ultrasound abdomen, we could pick it. I could pick it up early.
Correct.
So for second case, since everything was normal, but we cannot tell her. We know that there is something abnormal, but we cannot tell what is abnormal. So the investigation was extended to PET CT of the brain. So it was showing diffuse cerebral hypoperfusion. So it was suggesting cerebral atrophy. So at that point, like we were not sure of the diagnosis. We could just tell that there is some abnormality, but we are not able to find out what is the abnormality exactly.
So I think this has been a real eye opener. I recall random reading that you could also get, you know, your CSF showing autoimmune antibodies and paraneoplastic antibodies. Am I right? Because it tends to wash the entire brain.
I'm not sure about it.
Yeah, so if you were not to find it in the blood, then maybe lumbar puncture might help. So this is some random read. I don't know whether. I mean, I honestly have no experience, but I think we now all have to look back at the kind of patients whom we have dismissed as not certain from our end and referred to neurologists, because I'm quite sure that in neurology um, they won't give primary importance to such patients because they're very difficult to diagnose. So I appreciate the fact that you have followed up. So let's just go into the chat and see whether there are any questions which have come up on chat. I think Dr. Hanifa has asked a question. If features are suggestive of cerebellar symptoms with normal brain MRI, do you advise PET or autoantibody first?
First thing is better you go for a paraneoplastic workup, which is easier. Take a chest X-ray. If you suspect anything in that, do a CT chest. And in ladies, go for mammogram, USG abdomen, and maybe MRI pelvis also if you're strongly suspecting. And you can ask for a family history also, any malignancy, breast, anything in the family. So that should be the first thing to be done. And the next step, like if everything is normal, then you go for next level, PET. And autoantibody, like if you can already like prove a neoplastic condition without an autoantibody, you can claim it as a paraneoplastic syndrome. If everything is negative, then final resort is autoantibodies. Paraneoplastic panel is you can do paraneoplastic panel.
So I think the take-home message is for all of us to check whether paraneoplastic panels are available in our hospitals, so that if at all we need to ask, or if you have a strong neurology department, I think this will be almost always there. Am I right?
I
Because
don't think, sir, it's available everywhere. And that too is around, it costs 25 to 30,000. Our
okay.
first patient was not affording actually. So in her, like it was picked up in an ultrasound. Our second patient was very well affording. So we could do everything, and it became easier because they were affording.
So I think this is, as I said, been an eye opener. Would anybody in the group like to share their experiences of this condition? And just before I go on, I think I have a question for you, Dr. Danya. Are you publishing this? I hope you are, because this is fantastic.
Yes, now I should think about that.
Think? No, you should have done it by now.
Yes, sir.
Very good, because I think, I mean, believe me, it would be an eye opener to many people, because
Sure.
I think we just read about this as, a small line in the differential diagnosis. Nobody's.
I will tell you one more thing, sir. In multiple centers, even though she was evaluated, a VNG was not done. So much eye findings I could pick up. Even I was not thinking this much. When I saw the patient, actually, I would tell you that this is the first case of paraneoplastic syndrome which I encountered. So even when I saw the patient, I like it was a confusing case of vertigo. So when the VNG was done, I was really surprised. This much of findings in a patient with normal MRI. So it's a completely neurological finding. So I think the eye findings are diagnostic. Like in addition to MRI, when we do a VNG, that adds to MRI definitely. She was
Right.
having this much eye findings, and still her MRI was normal.
So actually, when people talk about vertigo with normal MRI, we tend to think of stroke in evolution or stroke which has been missed by the MRI. But I think now we should start having an index of suspicion for autoantibodies, paraneoplastic syndromes,
And I
etc.
would tell you one more thing: the teaching that when you have cerebellar findings, you should think of paraneoplasty. This teaching was by Srinivas sir.
Oh,
So,
very
like
good.
when I found the cerebellar to search for the paraneoplasty, the thing is, I'm seeing the cerebellar finding, but uh, the search for the paraneoplastic should come from us. So, if we don't think about that, we will not do it. We will
Very
not search for the
good.
this thing, malignancy.
Good and nice of you to acknowledge. I think that, but I think that is a take-home message which we should all treasure. That if you find a paraneoplastic syndrome, please look
If you find it like
cerebellar lesion. Look for
yeah,
paraneoplastic
that's
syndrome.
true.
So there's another question coming from Pratishta as to what are the common autoantibodies test. So any of you all could take it.
See, anti-O is the most common, which is seen in the breast and gynecological malignancies. And the other antibodies are the, like in small cell lung cancer, we have the, I'll just display this slide again.
I think you go back once.
Anti-VGCC is seen in, yes,
No,
anti-VG,
just go back once, right?
go back one here, I think it's here. No, it's behind.
Yeah,
Yeah.
that just stay there.
So
The
this
blue
is
slides.
actually, these are not neoplastic. So, like
So while you find it, I just give a tip, Pratishta. What happens is you have a panel of testing for paraneoplasm, and similarly, you would have a panel of testing. And if it is
Yes,
too
sir.
expensive, you could check the one particular thing which is suggested by the clinical diagnosis. So
Yes,
that
sir.
is my understanding of usually how these investigations are done.
Yes, definitely, sir.
So if you think there's a ovarian this thing, then you're looking for, as she mentioned, a specific test for that, and that since each one of them is priced differently, it's only a very as she put it, a very person who can afford a lot of money is put through all. But otherwise, you be very cautious as to what you choose. Chatia, you found this, right?
I
Good.
think we have got a lot of small cell lung cancer. Anti-Hu. Anti-Hu is under in males. Anti-Hu antibody in prostate cancer, small cell lung cancer, seminomatous. Other things are a bit rare. And this anti-VGCC is an autoantibody seen in non-neoplastic conditions also.
I think I can think of another study which one of your PGs could do as a thesis topic to study over a 1 year period all the paraneoplastic syndromes which have presented in neurology and backtracking the history as to how many of them had vertigo. So I think that is something which is worth studying. Of
Yes,
course, we are looking forward to your publication. Which journal are you thinking of?
So now you're giving me a motivation to publish it in a journal. So instead of
Oh, no,
saying,
no, no,
and
no,
I
no.
have a
There's
lot
no
of work
such
in
thing,
the
motivation.
hospital, so most of the energy is going in work. So I'll be publishing this anyway.
Oh, that's tragic. I think you must learn to have work-life balance and research balance. I think that you need to bring in the third this thing into it. Um, I think yours has been such a linear presentation that and that too of a topic which very few of us have actually had a lot of experience with. a lot of our knowledge is textbook knowledge. So, is there anybody in the group who wants to contribute a personal experience? We are more than happy to involve them. Any of our friends from abroad, have you all seen similar cases? Please tell us. Or if you've not seen cases, or like me, if you're suspecting that the case you saw 6 months back was this and I missed it, you could discuss it among friends. So I think this is brilliant.
Yeah.
Anybody
Yes,
wants
sir.
to say something, please?
Yes, sir. I just want to know, hi Danya ma'am, how are you? It's
Fine.
excellent. It's excellent case, ma'am. Actually, this is eye-opener case for us, actually.
Can you identify yourself, madam?
Ma'am, I'm Dr. Pratishtha Sachan from Lucknow.
Okay, good.
Yeah. So, ma'am, I just want to know that if we are thinking that there is a autoimmune origin, if there is, this is apart from this case, we are thinking that there is a bilateral involvement of the ear and patient responded to the steroid therapy. Should we go for the autoimmune management? We are not clinically catch up. What is the real diagnosis? So should go for this autoimmune antibodies test in these patients.
I did not get your question. So,
She's saying if the patient responded to medications.
yes, if the
Would
patient
we-
respond to diagnosis and if we can get a clear-cut diagnosis, no need to do this autoimmune panel at all.
No, what she said is, I don't have a clear-cut diagnosis, but the patient responded to my treatment. So
like respond to the steroid treatment.
yeah,
So
whatever
we
it is,
can
Steroid
think,
treatment.
yeah.
steroids.
So then we should go for these autoantibodies test or other panel for the like paraneoplastic, like they are
If the
responding for
patient is
the
if the patient is affording, I will say better you go for it. Because in
actually
our
these are very
second case,
costly
we were
tests.
not, yeah.
Yeah.
Because in the second case, we could not get a diagnosis after everything. And finally, her neoplasm was diagnosed just because the auto antibodies were assessed after 6 months. If it was not done, we would not have diagnosed a malignancy for years ahead. Just because
Yes,
it
ma'am.
was diagnosed, repeated after 6 months, it turned out positive, and
Absolutely.
then the suspicion came it would be paraneoplastic.
So Danya,
Ma'am,
I think
one thing
sorry.
more, one question. If the patient get depleted for B12 and thiamine vitamin level again and again after doing the full course of that between B12 and thiamine, should we think about autoimmune origin? I have the one patient, had one patient like I have given full course of thiamine and B12, and after 3, 4, or 7 months, they again depleted of these vitamins. So I'm thinking there is some autoimmune origin, and he again developed the vertigo symptoms. They are very mild symptoms, not as such as severe ataxia and all these, but there is a spontaneous nystagmus present. So we can think in these cases also there is a autoimmune origin.
So what I
I
understand.
mean, are you thinking of paraneoplastic or autoimmune?
Yes, sir, I am not clearly can say it's a paraneoplastic. It can be paraneoplastic or autoimmune origin. There is a again and again depletion of vitamin level in these patients. What I blood report I got that there is a again deficiency of vitamin B12 and thiamine level.
Yeah,
So
so
I'm thinking there is a
I get you. Danya, you want to take it? Rajiv, you want to take it?
Yes, sir. So basically, you are correct. You can consider an immune etiology because, as you know, that autoimmune or inflammatory bowel diseases can impair the vitamin B12 absorption. So that might be a different symptom. Not B12 deficiency might be actually a feature of the inflammatory disease, which is also affecting the inner ear. So if you look at the second article which I have posted,
yes,
it gives a clue regarding this. And I have seen many patients with inflammatory bowel diseases. In fact, just yesterday I had one patient with ulcerative colitis who came with bilateral vestibulopathy, which was progressive since the flare-up of ulcerative colitis about 5 months back. So we may not find adequate literature to support a diagnosis, but probably we are correct in assuming an inflammatory or autoimmune cause for the vestibulopathy.
Good.
sir. What antibodies test go for that? Like
No,
suggest me so that I can apply in the patient.
no, I think, Doctor, what Dr. Rajiv is getting at is we must stop looking at it entirely from the viewpoint of neurootology. we must try to expanding our horizon and start involving other specializations. So
Yes, sir. Yes, sir. Exactly. So I would suggest you take a gastroenterologist's help in your specific case to find out the cause for the B12 deficiency. So that would give a clue regarding the vestibulopathy also.
would you
Yes,
agree,
sir.
Dr. Danya? Would you have something
Yes,
else to
sir.
suggest?
Yes, sir. Like any cases, like if we don't get a diagnosis, and if like now, like our vertigo is not simply related to ear. So multi-system, it's a multi-system problem actually. So I think we should investigate the other areas also if we cannot get a complete diagnosis after fully ENT evaluation.
Okay, so that was absolutely fantastic. I've never spent a more, happy hour, if I may use the word. I'm not punning on it. So I, I think this has been a very good Vertigo Grand Round and one of the best. And I hope that, as I said, publications, a higher index of suspicion, involvement of other specialities are all take home messages from this. And I think this is the reason why we have this meeting with regularity. So I thank you, Dr. Danya, again. I, of course, thank Dr. Rajiv. Always a pleasure to have you. And I thank
Thank
all
you.
those who participated. I think we had a very, very useful time. Thank you very much.
Thank you,
So,
sir.
thank you
Thank
very
you, sir,
much.
for the invitation. Thank you
Not
so
at all.
much.
Not at all. We shall stay in touch, all of us. Okay, good.